should be live.
Afternoon. The last Tuesday in May. Time is marching forward. Here we are, well, we must be 10 weeks almost into COVID, something like that. It's getting up there. And of course, we're going to talk about COVID today. I want to bring up some important issues. We're starting to get the first reports on vaccines, and I think that's worth spending some time on. And also what else we're learning. And of course, here in British Columbia, and I know some of you are much the same over where you are in the world, we're starting to open things up a little bit. You can see I actually got a haircut finally, so that was a big bonus. It's always wonderful to get ready for summer. It's starting to feel like summer, although it's been relatively cool. So as we talk about things, COVID-19, everyone has been buckled down, homestay, and all these other issues. And I think it's fantastic that we're starting to open things up. The numbers suggest, and these are numbers on big numbers. They did 5 or 6% of all the people in Iceland, and they did a large number in New York State. So they found that nearly 20% of people, that's mid-April, as of mid-April, 20% of the people had antibody immunity to the COVID-19 virus, which is outstanding because it means we're part way to herd immunity. And I know that we've all been working on so-called flattening the curve so that we didn't overwhelm our hospital emergencies and intensive care units. But I think, they didn't get overwhelmed, not very much in Canada at all. And the other challenge about having everybody stay home is you don't create your herd immunity. So I was lucky enough to talk to a good friend of the family last night. He's in Toronto. He's a geriatrician, Dr. Barry Goldlist, and he was talking about care homes. Because, of course, I think 80% of the deaths in Ontario have been in senior care homes, because that's a very vulnerable group. We know this virus really hits people that are older, that have other health challenges. And the other thing we've been forgetting about is we've always been emphasizing this 2 meters and the respiratory droplet, but the virus is also in the air, okay? So it's 0.125 microns, that's pretty tiny. 2.5 microns lingers through the air and is transmitted throughout the world. And viruses certainly are already in Arctic and Antarctica. So viruses travel on their own. So many of us probably had this on North America, I would suggest in October, November.
Okay.
And so that's why it's not waiting for someone to come on an airplane. Airplanes matter for bacteria, because bacteria are 1 to 2 microns. They're quite big. They don't travel through the air near as much, but they travel with people in airplanes. So we've changed it now. We've said, well, the virus must come through the airplanes. Well, it's not that predictable because it tends to come through the wind currents. There's no other explanation that it would be in the ice in Antarctica and in the Arctic if it wasn't moving through the air currents. So viruses are tiny. They're not actually living beings, although we try to make them into living beings. But they are infective pieces of protein. Yeah, absolutely. So the other piece, that fits in with that, we have to talk about immunity. So it's fantastic now. There's at least 2 major ways to test immunity. There's one by Abbott, and there's another one. I guess Abbott right now is one of the most predictable. It's 99% active to whether you have antibodies or not. I mean, we'll be looking at getting our antibodies tested probably in June, because as we start to see people, it'll be reassuring to them.
Okay, so this is the antibody test.
This is the antibody test to see, did your body mount an immune response to this particular virus?
Okay.
So, and if we talk about that antibody, if enough people have the antibody, that is what gives you herd immunity, okay? And you don't have to have it 100% in the herd to have relative protection. So in a perfect world, we would take the very vulnerable people, so the people in the care homes, the people with major health troubles, and they would stay relatively quarantined or protected from the virus. And then if the rest of the community, this is what happens in the flu season every year, if all the rest of the community, so 70 or 80% of them have the virus, then the virus, by the time they've had it for 2-3 weeks, they've survived it, they've conquered it, they've got immunity, and now the virus relatively disappears.
Right.
So now the people in the care homes are safe.
Mm-hmm.
Okay? And so the corollary to that, you don't get near as long immunity from a vaccination. It's tragic, but it's true. And that's why we do top-ups of different things. Tetanus is every 5 to 10 years, depending on the number that you're considering in your relative locale. And many of the components of vaccine are the same. The challenge again is the coronavirus as a vaccine. We haven't successfully made one, despite several tries for quite a few years, 10, 15 years.
Mm-hmm.
So instead we're going to do it in 3 to 6 months. Well, the first one came out. They gave it to 24 people. I think they started on the 12th of March in Seattle.
Yeah.
And 3 of those 24 got quite sick. They call it stage 3. So 1 and 2 is mild to moderate symptoms of something. But by the time you're up to stage 3, those people are real sick. The kicker has always been with the viruses of this type. When we try to make a vaccine, we want to see if we get an antibody response, because we did that last time. We did it with the swine flu. We got quite a good antibody response. The problem was when some of these viruses, when you get the real virus, actually you do less well, and you can get really sick and potentially die from it. So that's what we're not showing yet. Ordinarily, we figure that out for a respiratory problem in the little animal called the ferret.
Okay.
Looks a bit like a weasel, but its respiratory system is very much like humans. And so that respiratory system mimics ours. And so they had a pretty good response with their coronavirus. They were really happy with it when they got antibodies responding. The kicker was when they got the actual virus, they almost all died.
All the ferrets.
Yeah.
Okay.
Because when you get the antibody response, it may not be the optimal one to prevent the infection. And it may actually weaken your ability to handle the real virus by, confusing, I guess you could say, the immune system.
Okay.
And you get an overblown cytokine response, and that was usually the cause of death. But this time we've short-circuited that,
Okay.
and we're going to test it in people. Well, I'm not lining up to be a volunteer, I'll be honest. They're going to do there's 6 different vaccines are about to start here and in Germany and, in the United States and in Germany. So I think those are brave people,
Okay.
personally. And as I've said before, and I don't know what your feelings are, but my feelings are, I would rather have the real virus than one of these possible vaccines, because the vaccines aren't going to give me the lifetime protection that the real virus could. I would rather do it when I'm healthy and well, relatively healthy and well, go forward, make my immunity, carry on.
Okay. So I'm going to back up a bit. When you were talking about herd immunity, you very quickly mentioned the need for top-ups. So can you just talk about why herd immunity doesn't apply to vaccinations and why we end up getting top-ups with certain vaccinations?
Yeah, I don't think, we know that we don't get the full-on body immune response from the vaccines that we have, certainly in the virus group. And, our best example would be the flu virus, of course, and just like the flu virus, this particular COVID-19 coronavirus also has a lot of strains of mutations. Viruses mutate much, much more quickly than bacteria. And as a consequence, we have some effect on the immune system, but we don't have a full boosting of the immune system for particularly that virus. And, the flu vaccine is a good example. Some years it will be 30% effective, some years it'll be 50% effective, some years it'll have 10% or less.
Mm-hmm.
And in fact, we know with the flu virus, because the flu virus has contamination with some coronavirus within it in the last 10, 20 years. And as a consequence, we know in studying in the people that had the flu vaccine in the last year or two, they did less well with COVID-19.
Mm-hmm.
They did about a third worse. So it isn't protective because that tiny trace of coronavirus, different than this one, confused the immune system is the best way I can interpret it. And by confusing the immune system, it's not quite as ready to full on act on this particular virus.
Okay.
Yeah. So herd immunity is what we would like to get, and we can get it with the regular infection. They're suggesting to us that we can create herd immunity with the vaccine, but that's a short-term gain thing, and my worry is that we won't have as much immunity, and my secondary worry is there will be strains to this virus that we're missing in the vaccine.
Okay. Well, that definitely makes sense.
So that makes a challenge to do that. So that's probably enough about that whole area. I'm very keen on vaccines, but I want them to be safe and effective. And right now I'm worried that this isn't going to be either one initially in the short term. So that's why it's great we're moving out into the world. And it's a good time to talk about, because you mentioned, I think last time, thyroid would be a good topic, and it is. It's a brilliant topic because it's very critical to optimize your immune system.
Mm-hmm.
If your thyroid particularly is low, your immune system is at half throttle. And the best way to think about it, well, throttle's not such a bad word, because the thyroid controls the metabolic rate of an entire body, every single cell. So not just brain cells, so that you're fuzzy thinking or not clear-headed, but it also is down regulates the function, I guess, of the neurons, and you tend to get feelings of sadness or depression or even anxiety. So those all fit in with hypothyroidism. Inability to keep the body warm. I mean, feeling cold all the time is a common symptom. And it's one that we frequently don't think about enough. And my personal opinion, and I write about this in my book because it's chapter 11 in the book, it's literally on thyroid, trying to give people an idea they may have a thyroid problem even though they've been tested with the standard test. Because the standard test in Canada, United States, is TSH, all right? Thyroid stimulating hormone, which is made by the pituitary gland in the brain, and it responds to circulating T3, and it responds to circulating reverse T3. So we'll talk about that in a minute, but it's a feedback loop. So theoretically, if you have enough circulating T3, the pituitary says, cool, we're good. We don't have to build any thyroid stimulating hormone. However, if it says that it's relatively too low, then it does build thyroid stimulating hormone. That goes to the thyroid gland, which is a butterfly shaped gland just below your Adam's apple. You know, you can probably feel it where it crosses just below the Adam's apple and the notch, thyroid notch, and butterflies in the side here. Okay, so when it's stimulated and working well, it produces T1, 2, 3, and 4, of course, and T4 is the ordinary way we store it. We store it inside the thyroid gland. However, to be active in the body, it has to be converted from T4 to the active form of T3. The T3 is converted in the liver, about 2/3, and curiously, 1/3 in the microbiome, in the bacteria of our gut. So we're back to that microbiome again, because it really matters. If it's a healthy microbiome, you're going to get decent conversion across. And it's also a dependent conversion on selenium and zinc. So you need, of course, iodine to build T1, 2, 3, and 4, because it's 1, 2, or 3, or 4 molecules of iodine. That's where the iodine is critically important. And then for the conversion from T4 to T3, you need the presence of enough selenium and zinc. So often, if I get a relatively borderline story about things, sometimes we can help people just by taking extra selenium 200 micrograms per day, and zinc 15 to 30 milligrams per day, and sometimes that will help people. Sometimes it will help people if we get them if we get them an improved microbiome and we get their liver functioning better. Remember things that shut down the liver? Glyphosate is my most hated one.
Yep.
And so that's why you got to get it out of the system if you're going to have a normal thyroid. And then the other piece that we talked a little bit about was the folks that seem to have a normal TSH. Well, sometimes the normal TSH has been created because the individual was chronically stressed or acutely stressed, and all of a sudden the T4 conversion instead of T3 goes to what we call reverse T3. And I learned that from Dr. Lewis Cady, the term the evil twin. Because the evil twin reverse T3, it doesn't act on the metabolic rate of your cells. It doesn't do what it needs to do. The downside, though, is the evil twin is seen as the pituitary. Cool, we got enough thyroid out there.
Okay, so it's still counting that as
But it doesn't
feedback
work.
loop.
So we get the message that we have enough, and so if we just measure T3, we're not there. So, and then if we go another little step, when I do thyroid, I like to aim, because I aim in myself now, for optimal health. I don't want to just be unsick, I would like to be optimal. So my goal is often to have the free T3 and the free T4 in that individual in the upper half of normal.
Okay.
So
Right, so if we were to test for TSH alone, which is kind of the standard, that's what doctors normally test for if they suspect hypothyroidism, then you could be missing all of these other markers, and the person could walk away, they've seen that they have a normal TSH, and they could actually be hypothyroid. And same thing if they're even on medication already. So if the doctor is prescribing medication according to the TSH, then they could even still be hypothyroid, even if they're on medication. Because
they could potentially be, because they, it combines into all of those pieces. And then the other particularly complex group, some of us will have our receptors will be relatively thyroid hormone resistant.
Yeah.
So that's a bit, we've all heard about insulin resistance, of course, in type 2 diabetes. And there is in some individuals that they need relatively more thyroid hormone than they would, but they become resistant to it because there were the receptor changes within the body.
Right.
That one's a little harder to test, but it goes back to very good clinical skills of listening to people. Unfortunately, very much in Canada, United States, and maybe in parts of Europe, we've become very lab test dependent. We want objective information. But, I know I'm long in the tooth. I'm 40 years practicing medicine. But in medical school, we learned 90% of what you're going to learn about that person is in the history. 5 or 10% in the physical exam, which can be critically important. It can be somewhat helpful in thyroid, certainly. But the labs are a small percent. And we're starting to learn more and more and more. The labs times take you down a rabbit hole which wasn't going to help you. You've got a spot in your lung in the chest x-ray. By the time you're finished investigating, you knew right at the outset it probably wasn't a cancer because of the other, but you spend a lot of time and a lot of money and potentially a lot of injury for the patient when you didn't spend enough time on the history and maybe physical exam part of it too.
Right, so we've talked about listening to the patient, we've talked about the blood tests, but there is actually, you can get an ultrasound as well, or you can have like a physical assessment of the thyroid. The ultrasound can be good for catching Hashimoto's ahead of time, even before the antibodies were to show up, so that can be a good thing to utilize as well.
And the ultrasound will often tell you if you have little cysts in the thyroid, which you need to watch. Most of them are benign, but they aren't all benign, so we need to catch.
And if you do, that being said, if you do have cysts or nodules on the thyroid, that's something you would want to monitor. So if you found them once, you would continue to be retested probably every year. Why don't we talk about treatment options? Because there are a lot of, or there's quite a few options for
Yeah,
actually treating.
well, and maybe even before that, why don't we get to some of the symptoms, because there's a lot of symptoms we
There
don't
is.
talk about,
Yeah.
but, certainly low temperature. So it's kind of fallen into disfavor now, but I know some people, if they test their temperature, they're consistently, 35.5, 36. And if they're consistently that and they have trouble warming up, and they've got some of the other signs, which we'll go over in a minute, it could well be the thyroid. So it's one to really think about. So temperature control is really one of the key ones, but then just the other thing, what about, how does it feel like a dimmer switch? Well, in some people, their libido, their interest in sexuality, is low, it goes down, and all of a sudden, they don't realize it, it's kind of crept up on them, but it's affecting how they feel about themselves and in their relationships. And then the other thing, of course, is fatigue or tiredness. Tiredness is tricky. The thyroid is a key place to watch for tiredness or fatigue, but of course it's all those other mitochondrial issues, which we'll talk about in a few weeks. So, because the control mechanism on the mitochondria is again the thyroid hormone. So that's what makes it. And then of course, we already talked a bit about depression, anxiety, sadness, but also dry skin, hair falling out. A very typical one that's often missed, and I can see it now looking across a room, is people, and often women, because they'll have a reduced amount of hair on the outside of their eyebrows, and sometimes it's quite shocking. It's almost a third of the way in, and that's inevitably thyroid that's been persisting for a while.
Right.
Of course, you have to ask the women, because some of them are very clever and they color it up, and you can miss it.
Yeah.
So you want to have a look at that and consider it, because I see that not uncommonly. So it's a physical part of the exam, and it's one part about looking carefully at people and then asking them, or asking if they've got a picture, or whatever, so that it might have been more obvious before they were made up to look more optimal.
One of the other ones that came as a surprise for me was the connection between hypothyroid and high cholesterol and cardiovascular disease.
Well, that's right. We know if the thyroid is low, then the triglycerides tend to come up. And that can be in the cardiac risk factor. And certainly, optimal function of the thyroid is really important for heart function. So it's one of the causes of heart failure. In fact, severe hypothyroidism can give severe heart failure. It used to be a big risk factor in anesthesiology, because if you anesthetize somebody who's very hypothyroid, they're going to do much less well with all their function, because their heart function is poor. And if you possibly can, then we defer it, put them on thyroid replacement, and start to solve that. But you can get heart failure from lack of thyroid alone. Not too common these days, but it used to be quite common. So the cardiac one is an important one, and it's an interesting historical one. I talk about one of the people in the book. This is a woman in her early 50s, had recurrent high heart rate, 100, 110 beats per minute. And she saw a cardiologist twice, the same one a year and 2 years apart, did a whole bunch of, Holter monitoring. That's the 3-day carry around monitors so you can watch your arrhythmia. And her resting pulse was still 100, 105. Nothing showed up. She was reassured, all was good. It was interesting because when she went on T4, and now we're starting to talk about different therapies, so she was put on thyroid as a symptom because her TSH was in that kind of middle range. It wasn't up in the range of about 5, which would be automatic that almost everybody should be on thyroid, and it wasn't down as low as 0.35 or whatever the number is at the bottom. It was kind of in the middle. So they put her on T4, she felt dreadful. So the next solution for her was either hormone replacement therapy or psychiatry. And I've some good friends that are psychiatrists. I mentioned Louis Cady earlier, but other ones too. They have become very aware you must really check the thyroid before you start into one of those, call them psychiatric medications, whether they're antidepressants or antipsychotic or whatever the group is, because the thyroid is much more treatable and much more easier to correct long term than incorrectly giving one of these other medicines.
Right.
Yeah. So the cardiac one, anyway, this individual, terrible on T4, but when they got put on pure T3 in a slow release fashion, which is available also, because it doesn't last as long in the body, within 2 days her pulse came down to 70 and stayed there.
Perfect.
So the whole deal was that, and she went on to say that she had about 18 of the 22 possible symptoms.
Mm-hmm.
Because she looked them up. I mean, people are wise today.
Yeah.
And they look it up, but they need to find, I guess, a friendly thinking physician who will look at those pieces. It's getting harder to do that today because they have protocols that the family doctors need to follow, and if you don't fit in the protocol, then woe is you. It's harder. And so that's why you end up trying to find a physician or a naturopath that's more skilled and talented and looking at the people that are kind of outside the regular group.
Right. Some of the other symptoms would be trouble swallowing. So I've seen that one before. And then you can have low stomach acid as well.
It tends to go with the hypothyroid.
Yeah.
And I think that's because the acid secreting cells, they're just half asleep because they're not getting enough metabolism rate to function optimally.
Exactly.
Yeah. Goes across.
Something else I found interesting was that you can actually be hypothyroid in different cells in different areas of the body. So you could have, for example, your pancreas not receiving enough thyroid while your digestive tract is receiving enough thyroid hormone.
Yeah, I wonder, I mean, one of those is maybe the digestive tract is converting some of the T4 into T3.
Mm-hmm.
So it's more active. And so you can be rescued by your microbiome, but it may not be enough for all the cells in the body, but just the ones in the immediate area. So it bring up a good principle, and that's why one of the tests or questions I always ask is, you know, do you have dry skin, especially your shins? Because curiously, the shins tend to be one that's kind of dry and flaky, although some people it'll be widespread. They'll be dry and flaky everywhere, and changes in their ridges on their skin, fingernails and so on.
Yeah.
So, but any time anybody wants to think about thyroid, I mean, a good place to start, because I spend several pages in the book, probably 8-10 pages, trying to talk about the subtle pieces that can be missed. And they can be missed. It's not necessarily the fault of your doctor, but when they're in a big hurry and you're trying to get these symptoms out, it breaks down. And that's why I always tell people, when you go to see your doctor, you only get one question, right?
Mm-hmm. So
don't ask your doctor how they're doing, because now you're done. You've had your question. Most of them don't do that, fortunately, but it could happen.
Okay, so we've got through the majority of symptoms. I don't know if we said insomnia. That's kind of an important one as well, that hypothyroidism can cause insomnia.
Yeah.
But I think we've pretty much discussed all of the symptoms, so maybe let's jump into the treatment options.
Well, the treatment options we've alluded to a little bit of. The typical one is something called Synthroid, which is a synthetic form of T4. Okay? So it needs to be converted in the body to T3. And it's been our standard for 35, 40 years, and people sometimes do well on it, but not everybody does well on it. So they finally did a head-to-head study, because the other common one, the one that I almost completely use, is desiccated thyroid, which is of pork origin, and it has some T1 and T2. It certainly has about 20-30% of T3, and it has T4. Okay, so the T3 can act immediately. It doesn't have to be transmitted or changed from T4 to T3. So then it isn't as critically affected by the liver optimization or the microbiome optimization, but the other components will be. And when they did a head-to-head study of the two, they found that people that were on the desiccated thyroid, because they did a double-blind crossover trial, they felt better on desiccated thyroid than they did on an equivalent dose of T4.
Mm-hmm.
The other interesting thing was the people on desiccated thyroid, they lost 2 or 3 pounds more weight, which is often a very attractive thing to many of us, especially women in the perimenopausal era, because they have more trouble with weight gain. And hypothyroidism is a tough road, often bound into weight gain.
Right.
Yeah. And you don't feel like getting off the couch, and so exercise is a distant idea.
Mm-hmm.
Tough. Very
Right,
tough.
so you've mentioned T4, which is levothyroxine, so not the best option, as per what we're saying so far. You've mentioned the porcine-derived desiccated thyroid, which is a good option because it has all of the different thyroid hormones available in it. And then there's also T3, which is leothyroxine, I believe, or no, it's leothyronine.
Yeah.
And I've seen that one prescribed alongside the desiccated thyroid sometimes as well.
Yeah, so it's a matter of, listening to the patient and working hard to get just the right optimization for them. And it's particularly challenging in those that have had, their thyroid removed, maybe for cancer or maybe an injury or whatever, because it's even more critical to find it. If you've got some thyroid function, it can often do that kind of smoothing out for you.
Mm-hmm.
But if you don't have any thyroid function, you've got to get it just right for that individual.
Mm-hmm.
I mean, I mentioned in the book a woman who was in her 30s, she had MS, and we've got a question about MS, so remind me to come back to that. But anyway, she was diagnosed at the Mayo Clinic with her MS, and she was also diagnosed as being hypothyroid, and they put her on T4, and she felt pretty well, but 9 or 10 months later, she didn't feel normal anymore. She went back to the Mayo Clinic, and they switched her to the desiccated thyroid, and she felt much better on it. It's a little more tricky to use the pure T3 because it's got a shorter half-life, and you have to get it spot on, and you probably end up taking it twice a day, although they try to do slow-release compounded T3 now, but it's a bit more of a challenge. So you need to find the right mix for that individual because we don't all fit in the regular path. I mean, 2 standard deviations, sure, that's pretty good for 95% of people. But if you're 2.5% on either side, you don't feel so good. So you have to have someone who's willing to personalize it, individualize it, so that you can be optimized, so that you can be as good as you can be.
Yeah. Okay, and then I wanted to mention the difference between treating thyroid and healing thyroid. So, I mean, we've talked about the medication treatment options, but what about the underlying causes for your hypothyroidism or your Hashimoto's or the thyroid cancer? So, I mean, just to take it even one step further, something that I heard that I really liked was the idea that there's a difference between glandular hypothyroidism and then cellular hypothyroidism. So, I mean, yes, on the one hand, we can have a lack of thyroid being produced from the thyroid itself, but in most cases, there's also this issue of the thyroid hormone actually getting into the cell. And that's happening because there's some sort of cellular stress going on. So, I mean, we're lacking this conversion of the thyroid hormone that occurs within the cells. And some of these stresses might include things like the microbiome imbalance, the liver toxicity, stress, trauma. What else can you think of?
Well, the one we talked a little bit before we went on the air, just with regard to the issue of thyroid hormone resistance. And I think this is part of what you mean. Most of us know that resistance idea much better from insulin resistance because that's what type 2 diabetes is. It's the insulin hormone resistance. So the cells don't react near as much and you need a much higher amount of insulin to what they're trying to do is open the insulin receptors so that they allow glucose into the cell. But if that isn't acting, it doesn't work. And so I think the same resistance or slight shift or change in the receptors, and I don't think we totally understand that yet, but we do know that some people will need an upping of their thyroid replacement so that they can cope with that in the resistance map. And I see many people will settle on desiccated thyroid at 30 or 60 milligrams, but some will need 125 or even 250. I've seen people up to 250 milligrams And then if, as they improve or get more healthy, sometimes that will drift down again. So you must, stay in touch with them if they don't feel right. When people are going on thyroid replacement, my favorite is to look at them and tell them, if you get any one of the 3 A's, and you can write this down or you can find it in the book, the 3 A's of anxiety, agitation, or arrhythmia. Okay, arrhythmia usually would be a rapid heart rate or intermittently rapid heart rate, so-called palpitations. Each of those are indications that you maybe need to bring down your thyroid. Or the best thing to do is quit taking it completely, get back in touch with your clinician so that you can get it resorted and do it. Virtually never do you need to do anything more in that case than quit taking it, because within a half a day or a day it starts to really come down. And rarely that's all you need to do. So the exception would be, of course, in the hyperthyroid, but we haven't got to that yet, so we won't go there yet. So part of you've already alluded to Hashimoto's. That was described by, a clinician in Japan many years ago. It's probably the most common cause or trigger of hypothyroidism, and it's felt to be due to an immune reaction against the cells of the thyroid, right? And so we can sometimes cross-test for that. So we do, other than the TSH and the free T3 and free T4 and reverse T3, and we can measure thyroid antibodies. Okay, so that means that there's antibodies against thyroid tissue, and we can do microsomal antibodies, and sometimes these are elevated. And that is a diagnostic tool 80 to 90% of the time of Hashimoto's. Mm-hmm. You can have thyroid, hypothyroid without having those elevated, but it's the most common reason.
Right.
So then you have to start teasing out, how can we help that? Mm-hmm. And this gets us back a little bit to the microbiome. I mean, we're smiling at each other because we're very much into microbiome issues. Yep. But exactly so, because almost all of these autoimmune diseases, such as Hashimoto's and so on, happen because of leaky gut. Meaning that the the cells of the lining of the gut are not tightly fitting together. They're getting weakness or opening of the tight junctions, and now protein from food gets into the bloodstream. The bloodstream does the correct thing, says that's a foreign protein, it's not supposed to be here, I'll put antibodies against it, and sometimes it molecularly mimics. So that piece of food that it's got an antibody against it, it might look a lot like the thyroid. Mm-hmm. Now you've got Hashimoto's thyroiditis. Okay?
Yeah.
And the other interesting thing about it, sometimes when we get that initial inflammation and swelling of the thyroid, we get some symptoms of hyperthyroidism. Mm-hmm. There may be days or weeks, and then people are really confused, because I feel I'm on a rev train, I'm really going fast, I got the arrhythmia, I got the agitation, I got the anxiety. Remember the 3 A's, a little bit too much thyroid hormone. And that's just because as the swelling occurs, it empties thyroid hormone out of the thyroid, and it's sending out more than it ordinarily optimally would.
Right.
So it's going through that bump, and then you're going to hit a wall, and now you're going to be hypothyroid.
Right. Yeah. So I was referring to the resistance that can happen, but also just the idea that there can be these underlying root causes of hypothyroidism or any of the other thyroid issues, even besides leaky gut. And there is one analogy that I really like, and that is the one of, so you're in the kitchen, you're cooking your meal, maybe for you and your partner, and a robber breaks in and they hold you up or they want to steal your stuff. You're not going to keep cooking your meal. You're going to drop what you're doing and you're going to deal with that robber. So your body and your thyroid are kind of the same way. If there's an invader in your body, say like some sort of bacterial, viral, or parasitic or other infection, fungal infection as well, then your body is going to divert its resources towards dealing with that. And so in those cases, sometimes that is where maybe the thyroid might shut down or slow down its production of thyroid hormone.
Well, sure, if it's involved in it. And so then you've got to look at the whole picture and get back to so-called normal or homeostasis. That's what we're always trying to aim for. Yeah. Mm-hmm.
I think, I mean, it's a good analogy, but I mean, ultimately, we just have to come back to these main things where it's like liver toxicity or toxicity in general, microbiome and leaky gut, and yeah, hypoxia.
Well, and it's not a bad analogy even with the healthcare system. I mean, you break your leg, easy. You got to get to the hospital, have to see an orthopedic surgeon, you got to get it fixed, plus or minus an operation, whatever. But that's acute care, and you can't look at that person's other health problems until you get the acute problem solved. So the chronic problem of the thyroid, or the chronic problem of, you know, the diabetes, it kind of gets pushed part way on the back burner, the same as everybody's worried so hard about the COVID-19 virus, that everything else has been pushed on the back burner, whether it's employment or schooling or just having time with family and friends. It gets pushed aside, but we need all those pieces. And the downside at the end of the day, when we look at COVID-19, we're going to see a lot of tough fallout problems, actually much more graphic and real, and even more causes of death than just the COVID-19 virus alone.
Yeah. I have a lot of nutritional suggestions for managing thyroid disorders, but I want to make sure that everyone gets their questions answered. So maybe we should.
Yeah, so we had the one question. So while you're looking at the other questions, if you want to bring them up.
Yeah, well, we've got. Could you talk a little about how fluoride displaces the iodine molecule in the hormone and does not show up in testing?
So that's an excellent question by Bruce. Of course, there's several elements that mimic iodine, okay? One of them is fluorine, one of them is chlorine, and one of them is bromine. And these are big factors in today's world because often they are really minimizing the effect of the thyroid, because by limiting the effect of enough iodine or not having enough iodine, the thyroid can't function, because the thyroid competes for the iodine, and it must compete with when you take in bromine. And bromine is a classic one because in the 1980s we switched iodine in making bread as a safety factor and part of the procedure to bromine. All of a sudden, everybody that ate significant amounts of bread didn't get enough bromine, or didn't get enough iodine because they had too much bromine. It's a relative issue for many of us because we have fluoride in our toothpaste and many other places, and sometimes in our water, or chlorine in our water. In each of these also compete with the iodine. I mean, I've heard some people, I think it was Dr. David Brownstein, who writes really good books on the thyroid, but he estimates that nearly 90% of people in North America are short of iodine. And everybody will poo-poo that and say, well, we've just got iodized salt, and we've added salt for 50, 70 years, but that only eliminated 95% of the problem. Well, if you're in that 5%, that's not so good for you. The other kicker is everybody has been into low salt, no salt. Consequently, nobody's getting the iodine enough anymore. So ideally you'll eat enough seafood and so on, but I am willing to and often recommend people take small amounts of iodine into their diet, or they can get it measured. And one way to measure it, to see where you are, you can do a hair analysis, and they will not just do heavy metals, but they'll do trace mineral analysis. Or there's a fairly challenging way that you can get your iodine measured, or you can take the history carefully and decide to use a small amount of supplementation. So fluoride interferes because each of those molecules mimic iodine. Without enough iodine, the thyroid doesn't work. And just before we leave that, another very common trigger for fibrocystic disease of the breast, and even some of the problems with the uterus, but with fibroids, is lack of iodine. Many people could really help their benign breast lumps and their fibrocystic disease of the breast with an iodine supplement. So iodine is used throughout the body, not just by the thyroid, but by other glands as well.
So, I mean, in terms of detoxifying those things, you're going to want to limit your exposure to them in the first place. But secondly, the way that you detoxify them from your body is by increasing your intake of iodine. And then I don't know if you remember, but bromine was in Mountain Dew, and I used to drink Mountain Dew.
Okay. So twice the caffeine and extra I didn't know they put bromine in it too.
Yeah.
I'm sure they had a reason.
Next question. Can problems such as neuroinflammation, lesions, latent viruses in the brainstem or lower brain, i.e. pituitary, cause metabolic or energy changes due to it affecting the thyroid?
Well, so now what you're doing, it's a good question, Roger, because the pituitary is linked to the thyroid. And of course, the pituitary is in the brain, and the pituitary gets messages from the hypothalamus. And MS is not a bad place to talk about that, because there's some indication that those that have MS usually have some problems within their hypothalamus. So anytime you have a problem in the hypothalamus, it could create a relative problem in the pituitary and therefore a relative problem in the thyroid, because they're all terribly linked and they all have feedback loops from one to the other, the so-called hypothalamic pituitary axis. All right. So any change within that, whether it's inflammation in the brain, infection in the brain, poor blood flow, even sometimes a stroke to the particular area, can interfere those things. And so that's why getting the whole thing sorted helps. The common theme that you've probably noticed in there is you want to get the inflammation down. Okay? So you want to get inflammation minimized. It's important for healing, but if it's overboard, it creates problems. It creates problems in the brain. That's anxiety and depression, headaches, the whole cross-section, and even eventually chronic inflammation, cognitive impairment, Alzheimer's, and so on. Inflammation in the thyroid, again, you want to keep it minimized. And I should tie in our question with MS, because someone asked, does everybody with MS have low thyroid? Well, I have MS, I have low thyroid, I'm on thyroid replacement for probably 15, 20 years. And consequently, they are tied together. And it's really important, I have found, because I've seen a lot of MS patients over the years, to try to help them. And thyroid is, I look at particularly closely, because it can get missed. I learned a long time ago in medicine, when you have one diagnosis, maybe it's rheumatoid arthritis, maybe it's MS, maybe it's diabetes, the doctor sometimes forgets to look at these other possibilities because they may exist in the same person. You can have more than one problem. Sometimes the problems are related, sometimes they're unrelated, but you can't ignore the other problem. It doesn't go away just because you're treating this one really good. You've got to get them all sorted. So thyroid replacement is a critical key one in MS, because MS people, 85% of us have low energy. I have met one or two in my lifetime that have normal energy, and good on them, that's all awesome, but the majority of people have low energy. So if you get the inflammation settled down in the MS, because everybody agrees on that, and you've heard my ways to treat it, and that's often extra blood flow and extra oxygen and improved gut microbiome, all of those things really matter, because it turns down that inflammation piece. And before I leave the microbiome, for that brain inflammation and even the one in MS, leaky gut. Leaky gut permits the entrance of LPS, or lipopolysaccharide, which is the remnants of the gram-negative bacteria in the gut. When they die, part of their membrane breaks down, and when those little packets get into the bloodstream, they go to the brain and everywhere else in the body, and they crank up inflammation. And so in the modern model for MS, that's what they used to trigger it, was they injected lipopolysaccharide, which is little tiny components, but they're small enough that they get through a leaky gut. Leaky gut has a lot of parallels equivalent to the other part of MS, which is leaky blood-brain barrier. And yes, the blood-brain barrier is the endothelial lining. It's the lining of all the vessels in the brain. But when LPS touches against that, it tends to cause an irritation, and it may cause inflammation and localized leakiness. So that's one of the triggers of the MS scenario. So thyroid can exist in the presence of, and again, because they may have that common theme of the leaky gut in the first place, and it must not be missed because it's a very treatable component for that person's energy. It may be part of the solution.
Right. We have another question. Do people with ME or CFS have low thyroid like people with MS do?
Sometimes. So ME is myalgic encephalomyelitis. Okay, the simpler name that we tend to use for it is chronic fatigue syndrome. By definition, those people have diminished working of their mitochondria, the energy power pack making part of the cell. And one of the control mechanisms of that is hypothyroid. Okay, so if you don't have enough thyroid hormone, it's one of the contributing factors. It's not the only one, but it must be listened to and carefully looked at because you don't want to miss it, same as you don't in MS. So not everybody has it, but some will. And you can optimize them better by optimizing their thyroid.
Okay. Well, we can talk about nutritional strategies.
Mm-hmm.
So there's this saying, you are what you eat, but to take it one step further, you're not just what you eat, you are what you actually break down and metabolize. So a lot of people with thyroid disorders have low stomach acid or reduced enzyme production. So step number one would be to try supplementing with something that helps boost your stomach acid and helps boost that enzyme production. So whether it's betaine and pepsin, or Swedish bitters, or taking apple cider vinegar before meals, or using enzymes themselves, these are all going to be things that are going to help you extract more nutrients from your food, and then therefore have a better ability to actually produce thyroid hormone and to work through the conversion as well. Second to that, I would say there are a number of key nutrients, which we've already alluded to a few times here. So iodine being a really important one, which you can get from seafood and seaweed. Number two would be selenium, which you can get from Brazil nuts, and you only need one Brazil nut a day if you tolerate nuts. If you don't tolerate nuts, you can take a selenium supplement. Some of the other important nutrients are zinc. So zinc is present in seafoods, especially clams and oysters. And you can also get zinc from wild or pasture-raised meats. One of the other important ones is thiamine, or vitamin B1. So this is important for carbohydrate digestion, and the dosage for this is about 400 to 600 milligrams per day, and that can be really helpful for improving your energy if you have a thyroid disorder. Magnesium is another one of the important nutrients. If you suffer from a thyroid disorder, that can be helpful too. And then iron as well, so making sure that you are taking in enough iron-containing foods.
Because you can also get that tiredness feeling of low thyroid can be aggravated if you're anemic. So your hemoglobin is low, and so you're not carrying the oxygen carrying capacity. We have another question, and it's a good question, and we kind of went by it, and I'll let you, well, first of all, how much apple cider vinegar? I think
just a capful, half a cup or a cupful.
Capful, not a cupful.
No, and you can put it in water if you don't like the taste.
And so Tammy has asked, if people have had their thyroid removed due to either throat cancer surgery or thyroid cancer surgery, she's particularly interested in the follow-up for that. And I think ideally you need someone to help follow you with it for several key, really important times. First of all, for the first 3 or 6 months after your surgery, you have to get things stable, because it will vary up and down a bit from residual components left within the body and as the body changes over to its new mechanism. So you may be given T4, but you may not do brilliant on T4, especially if you're unable to convert the T4 into the more active form in the body, T3. Remember that function on optimal liver function, and we'll talk a lot more about liver next week because we're going to talk about detoxification, and the liver is number one place. But also it's a matter of having that healthy microbiome, and you also need the cofactors present to convert it. And the cofactors being selenium and zinc, which are the main two. So once you've got those in place, after the first few months, you hopefully will be stabilized on your medication. If a major illness occurs or something, or some other major change, and the one I think of in young women is pregnancy, you must be exquisitely careful and ideally have someone who really knows what they're doing to help with the obstetrician to look at and adjust the thyroid during the pregnancy, because your replacement will have to change. It'll usually have to go up, and you don't want to be short of thyroid during the pregnancy for how you feel, but also how well the baby develops. And if the mom is extremely hypothyroid during pregnancy, that's where the term, unfortunately, cretin comes from, because the baby is born hugely hypothyroid and brain development isn't optimal or normal. So those are the pieces that you need to do, and then it starts to change again after delivery, plus or minus breastfeeding for that 6-12 months in that time frame, and then going back to the normal period. So pregnancy is exquisitely important. If you're on thyroid replacement or have had, for any number of reasons, one of them being throat surgery, as you mentioned, you've got to get that just right. And I've followed a number of people with that, and usually we can get it right, but sometimes we needed a tiny amount of thyroid hormone change, and my preference is still desiccated thyroid, and sometimes we need even some iodine regularly to somehow settle things down in the whole corner. Yeah.
Question: can thyroid function come back somewhat after 131?
Yeah, so I-131 is the radioactive treatment, which is one of the other treatments for hyperthyroidism. And sometimes there will be more recovery. It gets a huge onslaught, but it doesn't necessarily kill all the thyroid cells. So if it doesn't, then some of those will recover after the treatment. And an analogy is when they had the big meltdown in the Chernobyl equivalent in Japan, right? So some of those people are hugely exposed. And it's interesting that most of you will know this, but iodine is really hard to get a hold of, because if you get exposure to major radiation, iodine is the most protective thing to protect your thyroid. All right? And so remember I said nearly 90% of us are short of it, so that we need to do that.
Right.
Yeah.
I do have some other nutritional suggestions. So there have been some comparisons of different diets that you would use to support yourself if you have a thyroid disorder. My first suggestion would be to get off gluten and dairy. So food sensitivities are completely connected to thyroid disorders, and we see a lot of improvement when people get off the gluten and dairy. Second to that, I love Isabella Wentz's research, and she shared her results of what happens when her clients take on different diets for managing their thyroid disorders. And so she had some clients who chose to move from a SAD, so a standard American diet, to a vegan or plant-based diet, and she had some who moved to a paleo diet. And the numbers for this were the ones who moved, of the people who moved to the vegan plant-based diet, 50% of them felt better on that diet, and 50% of them actually felt worse. Likely because they're missing a lot of key nutrients in that diet, and it takes a lot of work to make sure you're actually getting all of the nutrients you require while on a vegan diet. Of the second group who went to a paleo diet, 90% or 95% of them ended up feeling better, and then it was like 5% ended up feeling worse. So definitely paleo seems to be a really good option, or a paleo style diet, because there are still even groups of foods that I would recommend including if you tolerate them, that the paleo diet doesn't. So for example, legumes, which help boost our bifidobacteria, those aren't typically included on a paleo diet. But yeah, I just like that.
Yeah, and it makes some degree of sense to me, because by eating meat, which is inevitable in the paleo diet, it often has more nuances. If the animals had healthy nutrients in their lifestyle, it's more likely you're going to have all those trace nutrients in your intake. And that's one of the, tricky places that come across. And, I'm glad you talked about the gluten, and that leads us into, in a few weeks, we'll be talking about gluten and dairy-free and so on. So I think we're up at the top of the hour.
Yep.
And so it's been, great again. We'll be at this again 4 o'clock next Tuesday. And our topic then will be detoxification, which I know many of my medical colleagues say, well, it doesn't matter. It all happens in the liver and it's good. But most of us are messed up. So of course, you'll get some tips on how to change that in solving the brain puzzle. And of course, if you haven't got today's Facebook Live option, or you're not on Facebook, you can tell your friends or family to go to drbillcode.com, DRBILLCODE.com, and click on blog. And Kristina's been good, and now we have them also in audio podcast form. So if you want to put them on your other, because I don't want you doing the video while you're driving,
Yeah.
but you can do the audio, and you can do it whatever you're puttering away at.
Exactly.
So I think that wraps it up. Stay well. Don't expect the vaccine to be ready tomorrow, and they're still working on it.
Yeah. Okay, thank you everyone. We'll see you next Tuesday.